Hi, all of you. Okay, just let us wait for more students to join. So let everyone join and then we'll begin the session. Good afternoon. Hi, I'm just waiting for others to join. NEET PG classes. I will take first. Just let me come back to India and then I'll take NEET PG classes also. Yes, Rajmeet, I am in Bishkek. Hi, all of you. Hi. Ahmed, you want me to finish the class early? Today the iftari time is early. If that is so, just in the message write what is the iftari time today. So I'll end the class early. Okay. So all the students, you have got today's PDFs. You have today's PDFs with you? Yes. Yes, Rajmeet, I am in Bishkek. So all of you have got today's PDFs. All the ISM students. Yes. Now, we will be talking about pregnancy-induced hypertension. Let more of you join and then let more of you join. I'll begin the class then. Okay. So, before we talk about pregnancy-induced hypertension, we should know what is hypertension defined in pregnancy? What do you call as high BP in pregnancy? Right? So high BP in pregnancy, हितेश एफएमजी की डेली क्लास नहीं होगी. एफएमजीई की डेली क्लास नहीं होगी. This is especially because today I am actually in Bishkek for a class, right? And I don't have church hall available today. That is why I am taking a class on YouTube just now. Okay? So this is especially for Bishkek students. They have received these PDFs. I am going to teach PIH over here for all the foreign medical graduates. Now suppose you do not have these notes, because if you are not a part of IMH, you will not be having these notes. So then in that case, just copy what you can copy. Otherwise, after the session is over, you can copy. Okay. Now, how do you define hypertension in pregnancy? Hypertension in pregnancy means that there is high BP, and how much high? If BP is more than equal to, if systolic BP is more than equal to 140 millimeters of mercury, or if diastolic is more than equal to 90 millimeters of mercury, or both. तो या तो systolic more than equal to 140 हो, or diastolic becomes more than equal to 90, or both. So many times we feel that if both of them should be present, then only it is going to be hypertension in pregnancy. Duri Ravi Shankar, I am only talking about hypertension in pregnancy. I am not talking about pregnancy-induced hypertension just now. I am asking you to tell me what is hypertension in pregnancy defined as. right? So hypertension in pregnancy is defined as systolic BP, either systolic BP more than equal to 140 or diastolic BP more than equal to 90 or both, and this should be present on two occasions. This should be present on two occasions, 4 hours apart. Two occasions, 4 hours apart, right? A very important thing to note is if BP is more than equal to 160 by 110, in that case, do not wait for 4 hours. Do not wait for 4 hours. In this case, you have to repeat the BP in 15 minutes and start the treatment. So then I am not going to say that I am going to wait for 4 hours, and if after 4 hours, 1 second, just if you people keep on typing, it will be our whole batch radio notes. Okay. 1 second. So you need PDF of this. This means you are not students of Bishkek. In one, do you have the link of my Telegram group? So if you have link of my Telegram group, just go and join. On that, I'm just sharing this PDF. I'm sharing it there. So that you don't keep on writing this and I get disturbed. Okay, I have shared it. It's going. So just wait for a few minutes. This PDF is being shared on my Telegram group. Okay. So I'm coming back to this. So just in case your patient's BP is more than equal to 160 by 90, then in that case you are not going to say that I will wait for 4 hours. In that case you are going to repeat BP after 15 minutes and start the treatment, right? Now once you know that your patient has hypertension, then you need to know that what type of hypertension is she having, whether she's having pregnancy induced hypertension, gestational hypertension, pre-eclampsia, why is she having this hypertension, what type of hypertension she is having. So for that, you will have to first understand the various terminologies, in which the first terminology which you have to understand is pregnancy induced hypertension. Now, pregnancy-induced hypertension means that the female was normotensive before pregnancy. During pregnancy, due to some placental pathology. During pregnancy, due to some placental pathology. Now, as a foreign medical graduate student, I don't want you to go into the details of what placental pathology. Simply remember that due to some placental pathology, and this placental pathology happens around 18 to 20 weeks, her BP increases, right? So in this patient, the increase in BP in pregnancy-induced hypertension, the increase in BP will be seen at more than equal to 20 weeks, right? And BP will come back to normal within 12 weeks of delivery. Within 12 weeks of delivery. So these are two very important characteristics of pregnancy-induced hypertension. Page number, पहला ही page है 144, right? Clear? So pregnancy-induced hypertension means that there is some problem in the placenta because of which the patient's BP is becoming high, and this problem happens around 18 to 20 weeks of pregnancy. And so the increase in BP is going to be seen after 20 weeks, and once delivery happens, within 12 weeks of delivery, BP comes back to normal. Now this pregnancy-induced hypertension, it can be of two types. It can be gestational hypertension or it could be pre-eclampsia. In both these cases, whether it is gestational hypertension or whether it is preeclampsia, the increase in BP will be seen after 20 weeks of pregnancy, and in both these conditions BP will come back to normal within 12 weeks of delivery. Right, so within 12 weeks of delivery, patient's BP is going to come back to normal within 12 weeks of delivery. Now the difference between them is, in case of gestational hypertension, proteinuria is absent and signs of end organ damage are absent. Whereas in case of preeclampsia, either you are going to get proteinuria or you are going to get signs of end organ damage. So if you are getting proteinuria, one second, am I not audible? Audio is not working? Is it so that the audio is not working? Tell me quickly, please. Okay. Now, in case of preeclampsia, either you are going to get proteinuria or you are going to get signs of end organ damage. Earlier it was said that if there is preeclampsia, proteinuria should be present, right? Now they say that either proteinuria should be present or signs of end organ damage should be present, right? Now, how do you define proteinuria in pregnancy? So, proteinuria means excretion of proteins in urine. And how much excretion? So, if you are doing by dipstick method, if it is more than equal to +2. So, on dipstick method, if proteinuria is more than equal to +2, or if the amount of protein excreted is more than equal to 300 milligrams in 24 hours, or if protein is to creatinine ratio is more than equal to 0.3. So proteinuria means on dipstick method, if you are getting more than equal to +2 proteinuria, amount wise, if we are saying, then if it is more than equal to 300 milligrams in 24 hours, so excretion of proteins more than equal to 300 milligrams in 24 hours, or if protein is to creatinine ratio is more than equal to 0.3, then we say that there is proteinuria. Now, what are the signs of end organ damage? Signs of end organ damage are, number one, platelet count less than 1 lakh. Number two, elevated liver enzymes. Elevated liver enzymes to more than 2 times their normal value. Elevated liver enzymes to more than 2 times their normal value. Then number 3, if serum creatinine is more than equal to 1.1. Number 4, if you are getting visual disturbances or cerebral symptoms. And number 5, pulmonary edema. So platelet count less than equal to 1 lakh, elevated liver enzymes to more than equal to 2 times their normal value, serum creatinine more than equal to 1.1, visual disturbances or cerebral symptoms, and pulmonary edema. Right? This is what is pregnancy-induced hypertension, and from pregnancy-induced hypertension, I have told you 2 categories, gestational hypertension and preeclampsia. In gestational hypertension, there won't be any proteinuria, there won't be any signs of end organ damage. In preeclampsia, either proteinuria will be present or signs of end organ damage would be present, or both of them would be present. Right? Now there is a term which is called as chronic hypertension in pregnancy. Now, chronic hypertension in pregnancy or overt hypertension in pregnancy, this simply means that a hypertensive female has conceived. So, if a hypertensive female conceives, then that is what is called as overt hypertension or chronic hypertension in pregnancy. So this is common sense that if a hypertensive female is going to conceive, the increase in BP will be seen from day 1 of pregnancy. In other words, the increase in BP will be seen before 20 weeks of pregnancy. The increase in BP will be seen before 20 weeks of pregnancy. And if it is a hypertensive female who has conceived, तो उसका BP प्रेगनेंसी से पहले भी इंक्रीज था, ड्यूरिंग प्रेगनेंसी भी इंक्रीज रहेगा एंड आफ्टर डिलीवरी भी इंक्रीज रहेगा, राइट? सो बीपी डज नॉट कम बैक टू नॉर्मल within 12 weeks of delivery. BP doesn't come back to normal within 12 weeks of delivery. So if there is a hypertensive female who has conceived, then we say there is chronic hypertension in pregnancy. So if you are getting a question in which they are saying that a pregnant female has BP, suppose the question is there is a pregnant female at 12 weeks of pregnancy, her BP is 140 by 84, right? So you have to tell me what is this patient having. So since her systolic BP is 140, although her diastolic BP is normal, I am going to say that yes, my patient is hypertensive. And because the increase in BP is happening before 20 weeks of pregnancy, I am going to say she's a case of chronic hypertension in pregnancy or overt hypertension, right? Then there is another term which is called as chronic hypertension with superimposed pre-eclampsia. Now, chronic hypertension with superimposed pre-eclampsia means that a hypertensive female has conceived. So, chronic hypertension की patient थी, a hypertensive female has conceived, and suddenly at 20 weeks of pregnancy, she experiences any one of the following, right? So, she is a hypertensive female who has conceived. Suddenly at 20 weeks, she starts having any one of the following. And what is that? Suddenly at 20 weeks, her BP becomes uncontrollable. Her BP becomes uncontrollable. Or she develops new onset proteinuria. Or she gets signs of end organ damage. End organ damage, right? So this is what will be called as chronic hypertension with superimposed pre-eclampsia. Now, I was telling you about pre-eclampsia and I told you in pre-eclampsia there will be two characteristics. Apart from the fact that the BP is going to increase after 20 weeks and the BP is going to come back to normal by 12 weeks, iske alawa bhi you are going to get two characteristics. One characteristic of pre-eclampsia is either they will have proteinuria, the other characteristic they may have end organ damage. अब ये जो pre-eclampsia होता है, you further classify it into mild pre-eclampsia and severe pre-eclampsia, right? So pre-eclampsia को we further classify as mild pre-eclampsia and severe pre-eclampsia. Mild pre-eclampsia का मतलब है BP is more than equal to 140 by 90 but it is less than 160 by 110, whereas severe preeclampsia means BP is more than equal to 160 by 110. Right? Again the same thing. Even if systolic BP becomes 160 or diastolic becomes 110 or more or both. So even if systolic, suppose there is a female whose BP is 164 by 140. She will also be, 164 by 90. So she will also be called as a case of severe preeclampsia. Either systolic BP should become more than equal to 160 or diastolic BP should become more than equal to 110 or both. Now these days we do not use the term mild preeclampsia and severe preeclampsia. Instead of the term mild preeclampsia, now we use the term preeclampsia without severe features. Preeclampsia without severe features. And for severe preeclampsia, we use the term preeclampsia with severe features. Preeclampsia with severe features. Right? So preeclampsia with severe feature means that BP becomes more than equal to 160 by 110. That is one criteria for saying that your patient has preeclampsia with severe features. The second criteria is if she is having signs of end organ damage, any sign of end organ damage, you are going to say my patient has preeclampsia with severe features. In preeclampsia without severe features, that is mild preeclampsia, signs of end organ damage are not seen. So there are only two criteria which tell you whether you are dealing with mild or severe preeclampsia. One is the BP criteria and the other is end organ damage criteria. Please, a very, very important note, and this note is oliguria, IUGR and proteinuria more than equal to 5 grams per day. So oliguria, IUGR or proteinuria more than equal to 5 grams per day, they are features of severe preeclampsia. They are not a diagnostic criteria for severe preeclampsia. Diagnostic criteria are only two. If BP becomes more than equal to 160 by 110 or if signs of end organ damage are present. IUGR, oliguria and proteinuria more than equal to 5 grams per day are features of severe preeclampsia. They are not a diagnostic criteria. Clear to all of you? Now, why am I interested in knowing that whether my patient has preeclampsia with severe features or not? Because if my patient has preeclampsia with severe features, in other words, severe preeclampsia, then there are two complications which can happen in my patient, right? So, two complications are seen in severe preeclampsia patients. Number one, in severe preeclampsia patients, you may get eclampsia, right? Now, what is eclampsia? Eclampsia is occurrence of generalized tonic-clonic seizures in a patient with high BP. So, in a patient of high BP, if you get generalized tonic-clonic seizures, then that is what is called as eclampsia. इसका मतलब ये हुआ कि severe preeclampsia के patient में patient any time can throw convulsion and she can become eclampsia, right? Because eclampsia is a complication of severe preeclampsia. तो इसका मतलब as a clinician I should know that what are those signs and symptoms in my patient which are going to tell me that my patient is about to throw convulsions. And this is not only important clinically, but it is very important from your exam point of view also. Questions बहुत पूछे जाते हैं on signs of impending eclampsia. So what are signs of impending eclampsia? Number one, अगर आपकी patient complain करे, severe preeclampsia की patient complain करे that she is having epigastric pain plus minus nausea, vomiting. If your patient says that she is having epigastric pain plus minus nausea, vomiting, you should immediately tell her to get admitted. If she is admitted, then you should immediately know that she is a patient of, she might throw convulsion at any time. Now, why does this happen? Why do you get epigastric pain? Epigastric pain happens due to subcapsular hematoma, subcapsular liver hematoma, and this subcapsular liver hematoma is going to stretch the liver capsules. So it will stretch the liver capsule, the glycine capsule, because of which there is going to be epigastric pain. So epigastric pain, I have written there, is due to subcapsular liver hematoma. If you cannot read it, I am saying it very clearly so that you can understand. Subcapsular liver hematoma, and this subcapsular liver hematoma is going to stretch the liver capsule. Right? No, this video will not be available after the class. Only for 1 hour it is going to be available, maximum 1 or 2 hours. And by tonight, I'm going to remove this video. Then, number 2. Second symptom is, if your patient is having headache, severe headache, which is not something which she had ever had usually. So it's not like a usual headache. Patient says, I'm having severe headache, right? And the third is if she starts having visual symptoms. Visual symptoms. These visual symptoms, they could be in the form of scotoma. They could be in the form of blurring of vision. They could be in the form of diplopia, right? So visual symptoms, any visual symptom which a patient complains of, and that is why in patients of severe preeclampsia, it is important to do fundal examination. Fundus ka examination is very, very important in patients of severe preeclampsia, because visual symptoms in a patient of severe preeclampsia are an indication of impending eclampsia. Clear to all of you? Yes? Any confusions here? Okay. Now, the second problem which can happen in patients of severe preeclampsia is HELP syndrome, where H stands for hemolysis, EL stands for elevated liver enzyme, and LP stands for low platelet count. I think this all of you know. So I don't have to tell over here anything more, but I need to discuss with you all the details related to HELP syndrome. Now, so there is something which is called as Tennessee's criteria for diagnosing HELP syndrome. Now, the Tennessee criteria for diagnosing HELP syndrome, it's the same. Hemolysis, elevated liver enzyme, and low platelet count. But how much? Low platelet count, how much? Less than 1 lakh. So if platelet count is less than 1 lakh. Then elevated liver enzymes. How much elevated? So liver enzymes elevated to more than equal to 2 times their normal value. Liver enzymes elevated to more than equal to 2 times their normal value. Then, so LP is low platelet count. Shiva, in fundal examination, you will also have to rule out retinal detachment, right? And there is something which is called as hypertensive retinopathy changes. Now, these hypertensive retinopathy changes, I don't know whether you are a foreign medical student who are asking this question or whether you are a NEET PG student. Now, for the NEET PG students, if you are listening to me, then all of you know that hypertensive retinopathy changes are what is called as, the classification is Keith-Wagner classification, right? So that is something which you are taught in ophthalm, the Keith-Wagner classification. Over here, I'm just telling you that you will have to get a fundal examination done in your patient to look out for changes of hypertension. So, LP is low platelet count, which is less than 1 lakh. EL is So Shubha, if you are a NEET PG student, then you know Keith Wagner classification more than me, right? You know that you get some silvery, wiry appearances of the vessels. Okay. So EL is elevated liver enzymes to more than their 2 times normal value. Now who's asking me? Amayanath, 5 times increased in liver enzymes. You are going to tell me 5 times increased liver enzymes किसमें मिलेगा? Hepatitis. If the liver enzymes are very much increased, then that means you are dealing with a case of hepatitis. Clear? Okay. So coming back to over here. I have told you Tennessee's criteria for HELP syndrome में LP, that is low platelet count, less than 1 lakh. Elevated liver enzymes to more than equal to 2 times its normal value. And H was for hemolysis. So Tennessee says that you just don't have to say that your patient is having hemolysis. For saying that hemolysis has happened, any 2 of the following should be present. If any 2 of the following are present, then you are going to say that your patient has hemolysis. So what are those 2? Out of these 4, any 2 should be present. So on peripheral blood smear, you should be able to see schistocytes or Burr cells, schistocytes or Burr cells. Then LDH levels should be high and haptoglobin levels should be decreased. Indirect bilirubin. Whenever there is hemolysis, there is increase in indirect bilirubin and it should be more than equal to 1.2 or severe unexplained anemia. So out of these 4, if any 2 are present, it means hemolysis is there. And for HELP syndrome, all this should be present. There should be low platelet count, there should be elevated liver enzymes, plus there should be hemolysis. Right? Now, 1 or 2 important things before I go ahead. In patients of HELP syndrome, in 85% cases, BP will be increased, right? But there will be 15 to 20% cases where BP will be normal, right? That is one very important point. Second important point about HELP syndrome is, just now when I'll talk to you about risk factors of PIH, I'll tell you PIH is more common in primigravida females. But HELP syndrome is more common in multigravida females. HELP syndrome is more common in multigravida females. Clear? Now, remember, PIH and all the complications which are happening due to PIH, they are happening. Why? Because I told you there is some placental problem, right? So all these complications are happening due to some placental problem. And as a foreign medical graduate student, you don't need to go into the details. As a NEET PG student, it is very important for you to understand the placental pathology which happens in PIH. But this class is for foreign medical graduate students, so I'm not going to go into the details of the placental pathology, right? So जो ये PIH होता है, ये किसी ना किसी प्लासेंटा की प्रॉब्लम की वजह से हो रहा होता है. So common sense tells me that अगर मैं पेशेंट के अंदर से प्लासेंटा निकाल दूं, but that doesn't mean कि during pregnancy निकाल दूं. That means if I terminate pregnancy and after delivery the placenta is out, so the problem of PIH will get over, right? So always in PIH, if I ask you what is the definitive management, so what is the definitive management in PIH? Definitive management always is termination of pregnancy. Termination of pregnancy. In other words, you are going to say that you are going to deliver the patient, or you are going to say I'm going to go for induction of labor. Right? Kalyan, yes, there are other risk factors for HELP syndrome, and one of them is a male fetus. Now, so the definitive management for PIH always is termination of pregnancy. In other words, I'm going to induce labor. So it is very important for us to understand कि कौन सी condition of PIH में कब pregnancy को terminate करते हैं. When are you going to terminate pregnancy? In mild preeclampsia, termination of pregnancy will be done at more than equal to 37 weeks. In severe preeclampsia, termination of pregnancy will be done at more than equal to 34 weeks. And if your patient has impending eclampsia, or if your patient has eclampsia or fetal distress or abruptio placenta due to PIH. All of you know that PIH can lead to abruptio placenta, right? One of the very important risk factors for abruptio placenta is PIH, and one of the very important complications of PIH is abruptio placenta. So if your patient is having impending eclampsia, fetal distress, या abruptio placenta, in that case you have to do immediate termination of pregnancy. Immediate termination of pregnancy irrespective of gestational age. Irrespective of gestational age. Right? Now, if your patient has developed HELP syndrome, in HELP syndrome, if gestational age is more than equal to 34 weeks, you will do immediate termination of pregnancy. But if gestational age is less than 34 weeks, in that case you are going to give corticosteroid. You are going to wait for 48 hours, and after 48 hours you are going to deliver. Right? So if gestational age is more than 34 weeks, you will immediately deliver. But if gestational age is less than 34 weeks, then you are going to give corticosteroids, you are going to wait for 48 hours, and then you are going to deliver. Right? Okay. Now, coming to pathophysiology of PIH. As I told you from such a long time, I've been just repeating this, that in PIH there is some placental problem, and that placental problem is going to lead to PIH. So when there is some placental problem in PIH, this placental problem leads to placental ischemia. Placental ischemia हो जाता है. And all of you know, जब प्लासेंटा का इस्कीमिया होगा, right, तो साइज क्या हो जाएगा? Size will be small. So if I ask you what happens to the size of the placenta in PIH, your answer will be size of the placenta in PIH becomes small. Clear? Now जब placenta का ischemia होता है, this placenta, all of you know कि placenta has a fetal side and placenta has a maternal side. So when there will be placental ischemia, it is going to affect both mother and fetus. Right? ऐसा नहीं है कि placental ischemia होगा and only fetus would be affected. Whenever there is PIH and due to PIH there is placental ischemia, it affects both the mother and the fetus. Right? How it is going to affect the mother? So what placenta does it, that when there is placental ischemia, vasoconstrictors are released. when there will be placental ischemia. And because of when vasoconstrictors will be released, placenta is going to throw all those vasoconstrictors in mother's blood. So due to placental ischemia, there will be increased vasoconstrictors in mother's blood. And because there will be increased vasoconstrictors in mother's blood, it will lead to high BP. And you know that high BP can lead to intracranial hemorrhage. So whenever there is PIH, there are increased chances of intracranial hemorrhage. अब इतना ही नहीं, all of you know from your class 10 knowledge, class 12 knowledge, that pressure and volume are inversely related. So if pressure is increasing, volume will decrease. So जब mother के circulation में BP high हो जाएगा, what is going to happen is the volume of blood going to all organs will decrease, and obviously volume of blood going to mother's brain will also decrease. So there will be decreased cerebral blood flow. So I am repeating, when there is placental ischemia, इस placental ischemia की वजह से problem केवल fetus को नहीं होगी, problem will be in both mother and fetus. Now the problem which happens in the mother is that when placental ischemia happens, lot of vasoconstrictors are released and placenta throws all these vasoconstrictors in mother's circulation, because of which mother का BP high हो जाता है, right? And you know, जब भी mother का BP high होगा, there will be increased chances of intracranial hemorrhage. किसी का भी BP high होगा, there will be increased chances of intracranial hemorrhage. And the other thing which is going to happen is, whenever there is increased BP, pressure and volume are inversely related. The volume of blood going to mother's all organs will decrease. In other words, volume of blood which is going to the mother's brain will also decrease. So there is going to be decreased cerebral blood flow. This decreased cerebral blood flow leads to cerebral hypoxia. And it is this cerebral hypoxia which is the reason for convulsions in eclampsia. So if someone asks you that why convulsions happen, right? Why convulsions happen, then you're going to say it is going to happen due to decreased cerebral blood flow. Amya, brain sparing effect किस में मिलता है? Brain sparing effect fetus में मिलता है, right? अगर ब्रेन स्पेयरिंग इफेक्ट हम एडल्ट्स में मिलता होता तो कभी भी स्ट्रोक जैसी चीजें ना होती, right? So when you are talking about brain sparing effect, that is seen in fetus. I am talking about mother just now. ये किसका cerebral blood flow decrease हो रहा है? I am talking about mother. This is mother's cerebral blood flow which is decreasing. And because of decrease in mother's cerebral blood flow, there will be cerebral hypoxia. And because of this cerebral hypoxia, there will be convulsions. And that is the reason why you get eclampsia. That is the reason why convulsions happen in a patient of eclampsia. Are you understanding? तो अगर हमें इस convulsion को in a patient of eclampsia रोकना है, what should I do? I should increase the blood flow to the brain. And that is what magnesium sulfate does. Magnesium sulfate brings about vasodilatation. And because it brings about vasodilatation, and वो brain पे काम करता है, peripheral काम नहीं करता. Magnesium sulfate acts on the brain and it brings about vasodilatation, and that is how it prevents and controls convulsions. Have you understood? Good. Now, along with that, what this placenta is going to do? Along with that, placenta is going to have more effect on the mother, and what it is going to do? It is going to damage. One second, just hold on. Yeah. So it is going to damage the maternal capillaries by releasing inflammatory mediators. So when there will be ischemia, not only vasoconstrictors will come in mother's circulation, but inflammatory mediators bhi aayenge in mother's circulation, right? And when inflammatory mediators are going to come in mother's circulation, it will make the blood capillaries leaky. Blood capillaries there will be tiny holes which will be seen. Right? Now imagine there is a pipe through which water and sand particles are going. Right? Water and sand particles are moving and you make tiny holes in that pipe. What happens? When you make tiny holes in the pipe, the water comes out. So the liquid component comes out, but the sand particles, they remain inside the tube, right? They remain inside the pipe. Same thing happens in capillaries. Now in capillaries, because tiny holes are made by these inflammatory mediators, so the liquid component of the blood will come out, and this liquid component of blood is going to collect in fourth space, right? And it is going to lead to edema. Right? So it leads to edema, it may lead to ascites also, right? Now, ye to hua that the liquid component comes out. Now what is going to happen? Now inside the capillaries, inside the vessels, only blood cells are present. And because only blood cells are present, there will be hemoconcentration inside the vessels. Now this is very important. Normally in a pregnant female, I have taught to all of you who are from Bishkek that normally in a pregnant female, yesterday only I told you that there is hemodilution. There is hemodilution. But if there is PIH, what is happening? Hemoconcentration is happening, right? So imagine एक vessel के अंदर blood cells are sticking to each other. And when blood cells are sticking to each other, there will be increased chances of thrombosis. And because of the increased chances of thrombosis, there can be multiple organ damage. So in PIH, in the mother, there is multiple organ problem. Right? PIH is a multiple in PIH, multiple organs are involved. The most common organ which is involved is mother's kidney. Right? I will talk to you. This is going to happen in third space. Alex, this is going to happen in third space. Third space fluid collection is going to happen. Okay. Now, the most common organ which is involved will be kidney. Apart from that, liver could be involved, and that is why one of the signs of end organ damage was liver enzymes raised. That is why one of the signs of impending eclampsia was epigastric pain, right? Then CNS. When the cerebral cortex is being involved, it can lead to visual disturbances. So again, visual disturbances, cerebral edema, they were signs of end organ damage, and they were also signs of impending eclampsia, right? Asif, yes, I am in Bishkek. Padh lo pehle. Let's complete this and then we will chat. So as I was telling you that the most common organ which is involved is maternal kidney. So many questions are asked on renal changes which happen in PIH. So first question which they ask you is most common organ which is involved in the mother due to PIH. Most common organ involved in the mother due to PIH is kidney. That's very, very important question. Second important question is, what is the characteristic histopathological lesion of PIH? So the characteristic kidneys histopathological lesion is glomeruloendotheliosis. Glomeruloendotheliosis. Number 3. Due to increase in BP in the mother का renal blood flow is going to decrease, right? And if mother's renal blood flow is decreasing, that means urine output is decreasing. In other words, in mother also you are going to get oliguria, right? Not only this, when renal blood flow decreases, GFR decreases. What is GFR? Glomerulo filtration rate. In other words, किडनी की फिल्टरिंग कैपेसिटी डिक्रीज हो जाएगी. तो अब किडनी इज गोइंग टू डू डिक्रीज्ड फिल्ट्रेशन ऑफ यूरिया, यूरिक एसिड एंड क्रिएटिनिन. तो अगर किडनी से कम यूरिया, यूरिक एसिड, क्रिएटिनिन इज गोइंग आउट, so in body what is going to happen? There will be increased urea, uric acid and creatinine. And that is why one of the sign of end organ damage was serum creatinine more than equal to 1.1. So are you understanding that why organ damage happens in PIH? Organ damage happens in PIH because the inflammatory mediators are released by the placenta, which lead to making the capillary leaky. And because the capillary becomes leaky, the liquid component of blood moves into the third space and there will be third space collection, whereas the blood cells are going to remain inside the blood vessels, which is going to lead to hemoconcentration, and that is going to lead to increased chances of thrombosis, right? So these problems are happening because PIH is affecting mother. Now, as I told you, placental ischemia not only affects the mother, placental ischemia will also affect the fetus. And I also told you that because of placental ischemia, the size of the placenta becomes small. So, agar placenta ka ischemia ho jayega, right, that means now the amount of blood which is going to the fetus will decrease. Yes. So, if there is placental ischemia, if there is the size of the placenta has become small, so obviously the amount of blood which goes to the fetus decreases. Now, in the class also I have told you that there is a fancy name for this condition, that when blood supply to the fetus decreases, that is called as uteroplacental insufficiency. So what is going to happen? Uteroplacental insufficiency. So all the Bishkek students, quickly type karo. There was one investigation which I told you should always do whenever there is uteroplacental insufficiency. Tell me that investigation quickly. In the link, in the chat, tell me the name of that investigation which I have told you. Which investigation you should do in uteroplacental insufficiency? Where are all of you? Doppler. Very good. कौन सा Doppler? I have told you that also. Which Doppler? Just writing Doppler will not do. Which Doppler? Doppler of which vessel? Meet, are you from Bishkek? No. Not uterine artery Doppler. Excellent, Dipankar. Umbilical artery Doppler. हमें क्या देखना है? हमें देखना है कि फीटस को कितना ब्लड जा रहा है. एंड फीटस को ब्लड जाने के लिए यू विल हैव टू चेक अम्बलाइकल आर्टरी. यूट्राइन आर्टरी के डॉपलर को देख के हम क्या करेंगे? I want to see how much blood is going to the fetus, right? And if I want to see how much blood is going to the fetus, which Doppler should I do? Umbilical artery Doppler, right? Okay. Now, because decreased blood goes to the fetus, so what is going to happen? Now, because decreased blood is going to go to the fetus, so there will be IUGR, right? And yes, यहाँ पे brain sparing effect मिलेगा. IUGR होगा तो brain will be spared. And in the fetus also renal blood flow will decrease. अगर overall blood कम पहुंच रहा है तो fetus की kidneys में भी कम blood पहुंचेगा. Fetus की kidney में कम blood पहुंचेगा, so fetus will produce less urine. And अगर fetus less urine produce करेगा, it is going to lead to oligohydramnios. Right? So this is how PIH can affect the fetus. In fetus, it can lead to oliguria, it can lead to IUGR. In mother, it can lead to end organ damage. Multi-organ damage can happen. Now, इस पूरे चीज को अगर हम समझ गए, so if I ask you, tell me what is the earliest sign of PIH, or what is the first sign of PIH? First sign of PIH is high BP. High BP is the first sign for PIH. So if you go on page number 156. Go to page number 156. On page number 156, I have written a question, first sign of PIH. So first sign of PIH is high BP in the mother. That is first sign of PIH, right? Now, although in PIH just now I explained to you कि edema होगा, I explained to you कि edema की वजह से there will be rapid weight gain, but edema and rapid weight gain are not a criteria to diagnose PIH, right? So edema and rapid weight gain are not a criteria to diagnose PIH. Clear to all of you? Edema भी मिलेगा, rapid weight gain भी मिलेगा, but they are not criteria to diagnose PIH. What is the most common organ affected in PIH? Kidney, right? Now, PIH is a high risk pregnancy, and if you remember, since last 2 days I have been telling you that whenever we have a high risk pregnancy, you have to do fetal monitoring. And fetal monitoring कौन से week से start करेंगे? 32 weeks से start करेंगे, right? What all are you going to do in fetal monitoring? Come on, tell me, all the students of Bishkek who are attending this, what all are you going to do in fetal monitoring? This is a repetition of the things which I have told you. Repetition है ये. जल्दी बताओ, what all investigations are you going to do? Meet, high BP is not a criteria for help. Tennessee criteria में कहाँ बताया मैंने high BP is a criteria? So number 1, you are going to tell the mother to keep a track of fetal movement. Number 2, you will have to do NST or biophysical score, and as I told you, high risk pregnancy में preferable होता है twice weekly. And because there is uteroplacental insufficiency, I will do umbilical artery Doppler. Umbilical artery Doppler. So we will tell the mother to keep a track of the fetal movement. Then we are going to do NST and biophysical score twice weekly, right? And because she is having uteroplacental insufficiency, umbilical artery Doppler. Fetal heart rate नहीं देखते हैं. This is what we see. You are not going to say fetal heart rate. You are going to say NST. Now, apart from that, you will have to do ultrasound. I am going to do ultrasound in the mother because I have to, number 1, check amniotic fluid levels. because there are chances of oligohydramnios, right? Number 2, I am going to look for IUGR. That is why ultrasound should also be done in patients of PIH. Clear to all of you? That is how you are going to do fetal monitoring. Now, screening for PIH. If I ask you, how do you go for screening for PIH? Screening for PIH, it should be done in all pregnant females. It should be done in each antenatal visit. It should be done in all pregnant females. It should be done in each antenatal visit. And for screening, you are going to measure BP and you are going to look for proteinuria by dipstick method. Proteinuria by dipstick method. So screening for PIH has to be done in all pregnant females, in each antenatal visit, and in each antenatal visit I'm going to check her BP and I am going to do check for proteinuria by dipstick method. Right? Now go back to your same page which we were doing, which was your page number 149. I have to tell you about risk factors for PIH. Now, risk factors for PIH, I have divided it into 2 columns because if you look at this right hand side column, you don't need to mug it up. Just by looking at all this, you can say that yes, patient may have PIH. If there is previous history of Pre-Eclampsia, if there is mother or sister's history of Pre-Eclampsia, if female is obese, if she has kidney disease. Now, I was telling you yesterday also and day before yesterday also, there are only 4 places where direct questions on risk factors will be asked. And this is one of the place. PIH में direct question आता है risk factors पे. So risk factors in PIH are important. They should be on your fingertips, right? So if there is previous history of pre-eclampsia, mother या sister की history है pre-eclampsia की, patient obese है या kidney disease है, then there are increased chances of PIH in my patient as well. That becomes a risk factor. Now, understand that ये जो placental pathology हो रही थी, right, जिसकी वजह से PIH हो रहा था, so there was a placental pathology where, and that placental pathology was leading to PIH. Now, when we studied that why this placental pathology happens in few patients, we realized that in some patients there is exaggerated immune response. There is exaggerated immune response जिसकी वजह से there is this placental pathology जिसकी वजह से PIH होता है. तो एक फीमेल में, प्रेग्नेंट फीमेल में जो ये एग्जैजरेटेड इम्यून रिस्पॉन्स होगा, ये किसी फॉरेन एंटीजन की तरफ की वजह से होगा. एंड प्रेगनेंसी में वो फॉरेन एंटीजन होता है फीटस. एंड फीटस में वी नो कि 50% जीन्स मदर से आते हैं एंड 50% जीन्स फादर के होते हैं, पैटर्नल जीन्स. तो एक्चुअली ये जो एग्जैजरेटेड इम्यून रिस्पॉन्स होता है, दिस इज अगेंस्ट paternal genes. It is against paternal genes, right? So this means that PIH will be more common if a female is getting exposed to the paternal genes for the first time. In other words, primigravida females. So PIH is more common in primigravida females. Not only this, मान लो पेशेंट का पार्टनर चेंज हो गया, राइट, एंड उसकी प्रीवियस प्रेगनेंसी वाज फ्रॉम प्रीवियस पार्टनर. अब अगर पार्टनर चेंज हुआ तो अब ये वाले जो पैटर्नल जीन्स हैं ये इसके लिए फॉरेन जीन्स बन जाएंगे, राइट? सो न्यू पैटर्निटी. new paternity. Right? Then, number 3. वो कंडीशन जिसमें पैटर्नल जीन्स ज्यादा होते हैं. Tell me what condition is that? In which condition do you get more paternal genes? Molar pregnancy. Molar pregnancy. So primigravida, new paternity, molar pregnancy. Number 4. As I told you that PIH is happening due to placental pathology. So अगर placenta का size बढ़ जाएगा, again the chances of PIH are increased. Right? And placenta का size कब बढ़ता है? Placenta का size बढ़ता है in twin pregnancy. Placenta का size बढ़ता है in diabetes. Placenta का size increase होता है in RH incompatibility. Now, exaggerated immune response. Exaggerated immune response, immune related conditions में भी मिलेगा. And one immune related condition which leads to PIH is antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome. Right? So the risk factors for PIH are, if there is immune, if the mother is getting exposed to paternal antigens for the first time, like primigravida, if she has a new partner, that is new paternity, if she is a case of molar pregnancy, or immune related problem like APLA, or if the size of the placenta is big like twin pregnancy, diabetes and RH incompatibility. So these are all reasons or risk factors for PIH. Clear? Very, very important is primigravida. You get confused. So many times you people mark multigravida as a risk factor for PIH. It's primigravida as a risk factor for PIH. And now you've understood the logic, so I'm sure you are not going to make this mistake. Now comes prediction of PIH. Can I predict अगर मेरे patient में high risk है for PIH? So suppose I have a diabetic patient, right? And diabetes is a risk factor for PIH. So can I predict that whether my patient is going to have PIH or not? Yes, I can predict, and prediction can be done by uterine artery Doppler. Now, in uterine artery Doppler, normally in a uterine artery Doppler, during diastole, you get a notch. So during diastolic phase, you get a notch. Right? And this notch disappears by 22 to 24 weeks of pregnancy. This notch disappears. But if this notch persists beyond 22 to 24 weeks of pregnancy, it indicates that in this pregnancy, your patient will develop PIH. Now, NEET PG students, you need to know more predictors, which I'm not discussing here. FMG students, you just need to know uterine artery Doppler. An outdated test is rollover test. If you ask me that do we have tests for prediction? Yes. Do we use them? No. Right? Their sensitivity and specificity is very less. So we don't use any of these tests for predicting PIH. Right? Now, can we prevent PIH? Yes. We can prevent PIH by giving low dose aspirin. Low dose aspirin. So, एक तरफ तो I'm saying कि we do not use these tests for predicting. And on the other hand, I am saying कि we use low dose aspirin to prevent PIH. So, we use low dose aspirin to prevent PIH in females with high risk of developing PIH. Example, diabetic patient, kidney disease patient, right? So in all those females who have high risk of developing PIH, we give them low dose aspirin. And this has to be started from 12 weeks of pregnancy and it has to be continued throughout pregnancy. Right? कितनी dose देंगे? 75 milligrams. 75 milligrams daily. Now please understand that there is no role of low salt diet. There is no role of absolute bed rest. There is no role of antioxidants. There is no role of fish oil. Right? There is no role of these things in preventing PIH. Another one very important thing which is seen is that in patients with low calcium, see here. You didn't actually have to write anything here, na? You just had to write low dose aspirin 75 mg. जो मैंने यहाँ डायबिटीज और किडनी डिजीज लिखा है वो यहाँ पे भी लिखा है. Okay. Copied all of you. Anything left? Bishkek students, anything left? Okay. Dr. Tamil, see, I am teaching PIH in short. So if you don't know anything about PIH, if you want to revise your concepts, the most important points on PIH, this is the crux of PIH. Right? Most of the time questions come from what I am teaching. There are few other things which as a NEET PG student you should be knowing, and that is other predictors of PIH, the pathology related to PIH. These are few very, very small things which you should be knowing apart from what I'm going to take today in this lecture. But I am going to tell everything important in this lecture. Apart from that, there are very few things which you need to know as NEET PG student. Now, in patients with low calcium, it is seen that if you give them calcium, then it prevents PIH. So, as such, calcium doesn't have any role, but in patients with low calcium, if you give them calcium, then it can prevent PIH, right? So we've talked about risk factors, we've talked about the various types of PIH, we've talked about prevention of PIH. Now let's talk about management of PIH. Now in management of PIH, we have symptomatic management and definitive management. Definitive management, as I told you, is always termination of pregnancy. Now I'm going to tell you symptomatic management क्या होता है PIH का. अब symptomatic management में there are two symptoms which we have to treat. One symptom is I have to treat her high BP. And the other symptom is I have to give a drug which can prevent as well as treat convulsions in PIH. So to control BP, I am going to give antihypertensives. I'm going to give antihypertensives, and drug of choice to prevent and treat convulsions in pregnancy is magnesium sulfate, right? Now, role. What is their role? When you give antihypertensives, then antihypertensives, they decrease the chances of intraventricular hemorrhage by decreasing the BP. So antihypertensives, they do not lead to prevention or treatment of convulsions. Antihypertensive केवल BP को decrease करेंगे, जिसकी वजह से चांसेस ऑफ इंट्रावेंट्रिकुलर हैमरेज डिक्रीज होगा, राइट. If I want to prevent or treat convulsions, I need a drug जो कि ब्रेन पे जाके एक्ट करे and cerebral vasodilatation कराए, right? So drug of choice to prevent and treat convulsions in PIH is magnesium sulfate. Please remember, magnesium sulfate is not an anti-epileptic drug. Do not say that the anti-epileptic drug of choice is magnesium sulfate. No, it's not an anti-epileptic drug. Magnesium sulfate decreases convulsions only if BP of the patient is high, right? Next thing, what is the indication for using antihypertensives? Indication क्या है? So indication for using antihypertensives is, number one, if BP is more than equal to 160 by 110 millimeters of mercury. If BP is more than equal to 160 by 110 millimeters of mercury, that is, then you have to start antihypertensive. Now, how is the question going to confuse you? Question कहेगा कि there is a patient in whom BP is 162 by 108 or 162 by 100, and what is the next step? Now, जैसे ही BP 160 से ऊपर गया, it means it classifies as severe pre-eclampsia. Either systolic has to be more than 160 or diastolic has to be more than 110. But then next step में आप ये नहीं कहोगे कि next step is giving antihypertensive. Why? Because उन्होंने केवल one reading दी है with high BP, right? So whenever you have to start antihypertensives, you should always have two readings. Always. For antihypertensives, you need two readings. If BP is 160 by 110, then the second reading will be taken after 15 minutes. After 15 minutes, you are going to take a second reading, and second reading may be agar BP high aaya, then I'm going to start antihypertensive. That is one indication for starting antihypertensive. Second indication for starting antihypertensive is if BP is more than equal to 150 by 100 persistently. So persistently your patient's BP is more than equal to 150 by 100. Then also you have to start antihypertensive. Clear to all of you? Yes? Now what is the indication for giving magnesium sulfate? Now, as I told you, magnesium sulfate can prevent and treat convulsions. So, in what conditions will you use magnesium sulfate to prevent convulsions? तो convulsions को prevent करने के लिए magnesium sulfate को use करते हैं in severe pre-eclampsia patients, in impending eclampsia patients, and in HELP syndrome. As I told you, HELP syndrome is a complication of severe preeclampsia, and in 85% patients of HELP syndrome, BP of the patient will be very high, right? And they may throw convulsion at any time, and that is why you have to give magnesium sulfate to prevent convulsions in patients of HELP syndrome. In which condition are you going to use magnesium sulfate to treat convulsions? It will be used to treat convulsions in eclampsia, in patients of eclampsia, right? So indications for using antihypertensive was if BP becomes more than equal to 160 by 110 on two readings 15 minutes apart, or persistently BP is more than 150 by 100. Indications for magnesium sulfate are to prevent and treat convulsions, and I have told you. I will be telling you about Pritchard regime. Don't worry, sab bataungi. Now, talking in detail about antihypertensive agents. Which antihypertensive agents can be used in pregnancy? So number 1, you can use labetalol. Number 1. Number 2, labetalol is alpha and beta blocker. Number 2, you can use hydralazine. Number 3, you can use methyl dopa. Number 4, you can use nifedipine. Number 5, you can use nitroglycerine. Number 6, you can use sodium nitroprusside. Right? So labetalol, hydralazine, methyl dopa, nifedipine, nitroglycerine, and sodium nitroprusside. Now the antihypertensive agents which are contraindicated in pregnancy are ACE inhibitors, ARB. What is ARB? Angiotensin receptor blocker. That is losartan. Right? Then your diuretics. Then beta blockers and diazoxide. Clear? Have you all copied this list? Now, if you've copied this list, let's do a few important single liner questions which are asked from this list. Antihypertensive of choice in PIH or pre-eclampsia. If a simple question comes, antihypertensive of choice in PIH or pre-eclampsia, what will your answer be? Labetalol. Antihypertensive of choice in hypertensive crisis. Okay. Right. जल्दी कॉपी करो. All of you. Okay. Copied. Shashi Bhushan copied. Chalo. Now, antihypertensive of choice in hypertensive crisis. What do you mean by hypertensive crisis? Hypertensive crisis means when BP becomes more than equal to 160 by 110. Right? In that case also I will use labetalol, but I'm going to use it IV. Best is IV labetalol, but second best will be hydralazine. IV hydralazine. What is the antihypertensive of choice in chronic hypertension in pregnancy? In chronic hypertension in pregnancy, now they say the antihypertensive of choice is alpha methyl dopa. Alpha methyl dopa. Earlier it was labetalol for chronic hypertension in pregnancy. Now it is alpha methyl dopa. If they ask you which is the safest antihypertensive, alpha methyl dopa. Right? Shailesh, you are a NEET PG student or FMG? अगर NEET PG student हो तो doses चाहिए. FMG में they are not going to ask you doses of labetalol. Okay? So safest antihypertensive is alpha methyl dopa. Antihypertensive which cannot be used in hypertensive crisis. You cannot use alpha methyl dopa because alpha methyl dopa is very slow acting. Alpha methyl dopa is very slow acting drug. Next question is, which is the drug of last resort? So which antihypertensive are you going to use last? That is drug of choice for refractory hypertension in pregnancy. Drug of choice for refractory hypertension in pregnancy. So what is that drug? The drug which is the last choice drug is sodium nitroprusside. Sodium nitroprusside. Sodium nitroprusside can lead to cyanide toxicity, right? So sodium nitroprusside, it can lead to cyanide toxicity. So it is the drug of last choice. Last major drug I'm going to use will be sodium nitroprusside, right? Okay. Then comes magnesium sulfate. Now, about magnesium sulfate, I have told you a few things, the indications for using magnesium sulfate, right? Now, let's talk about the actions of magnesium sulfate. Since the beginning of the class, I have been telling you that magnesium sulfate का action जो होता है वो centrally acting होता है. Magnesium sulfate, yes, Ashish, that is why I said कि this answer has changed. क्योंकि मैरो नोट्स में लास्ट ईयर तक आई हैड मेड यू राइट कि द ड्रग ऑफ चॉइस फॉर क्रॉनिक हाइपरटेंशन इज लैबिटोलॉल फॉलोड बाय मिथाइल डोपा. दैट इज वाई जब मैंने ये बोला लाइन की द ड्रग ऑफ चॉइस फॉर chronic hypertension is methyl dopa, I added this line कि this answer has changed now. So you are going to now mark the answer as alpha methyl dopa. The guidelines have changed. Okay. Now, magnesium sulfate acts on the brain. It is centrally acting drug. It blocks NMDA receptors in the brain. It brings about vasodilatation and it blocks calcium channels. Now, because it is bringing about vasodilatation, that is why it is going to prevent and treat seizures. Number 2, because it blocks calcium channels. That is why, please remember, magnesium sulfate should be used very, very cautiously with calcium channel blockers, right? So, calcium channel blockers के साथ we avoid using magnesium sulfate. Now, Puneet, nifedipine by sublingual route is contraindicated in hypertensive crisis only. तो hypertensive crisis में nifedipine by sublingual route is contraindicated. But you are going to give nifedipine as a delayed, sustained release tablet or even as an immediate release tablet, but you're going to give it orally, not sublingually. So ऐसा नहीं है कि nifedipine overall is contraindicated in hypertensive crisis, only by sublingual route हम नहीं यूज करते. उसका रीजन ये है कि जब आप nifedipine की टैबलेट को sublingually देते हो, then BP immediately drops. There is hypotension, right? And we do not want hypotension in the mother. Why? क्योंकि अगर मदर में हाइपोटेंशन हो जाएगा, then there will be again a problem to the fetus, right? So I do not want to over treat hypertension. I do not want the mother to develop hypotension, right? Coming back to Pritchard regime. So the regime which is used for giving magnesium sulfate, the one which we commonly use in India, and you should be knowing each and every detail of that regime, is Pritchard regime. Now, as per this regime, I am going to give loading dose of magnesium sulfate, right? And then after every 4 hours, I am going to give maintenance dose. And when I'm going to give maintenance dose, I'm going to continue it till delivery or till 24 hours after last convulsion. 24 hours after last convulsion. Whichever of these events is happening later, right? So I am going to give magnesium sulfate till 24 hours after delivery, or till delivery or till 24 hours after last convulsion. Sorry, please change it here. Please change. Sorry. It is till 24 hours after delivery. So I'm repeating. वहां notes में add कर लो till 24 hours after delivery. So magnesium sulfate में loading dose देंगे. Every 4 hours you are going to give maintenance dose, and then you are going to continue maintenance dose till 24 hours after delivery or till 24 hours after last convulsion, whichever is later. 24 hours is not added in your notes. Please add it there. Till 24 hours after delivery. It's not till delivery, it's till 24 hours after delivery. Now, जब हम loading dose देते हैं magnesium sulfate की, you have to give IM plus IV, whereas maintenance dose is only IM. Loading dose होती कितनी है? Loading dose is IM 10 grams, which you have to give 5 grams in each buttock. 10 grams, which you have to give 5 grams in each buttock. पुनीत, लोडिंग डोज का मतलब होता है कि जब पेशेंट कन्वल्जन आपके पास थ्रो करते हुए आई, तो उस टाइम पे जो आपने डोज दी, दैट इज लोडिंग डोज. जो फर्स्ट डोज दी, दैट इज द लोडिंग डोज. राइट? फर्स्ट डोज देने के बाद आफ्टर एवरी 4 आवर्स आप मेंटेनेंस डोज देते हो. सो लोडिंग डोज में हमें इंट्रामस्कुलर भी देना होता है मैग्नीशियम सल्फेट, एंड आईवी भी देना होता है. इंट्रामस्कुलर आई एम गोइंग टू गिव 10 grams, and जिसमें you have to give 5 grams in each buttock, plus you have to give 4 grams IV. जो 10 grams IM डोज होती है, this is 10 grams 50% magnesium sulfate. 10 grams 50% magnesium sulfate. जो IV डोज देते हैं 4 ग्राम की, that is 4 grams of 20% magnesium sulfate. Right? So IM डोज जो हमें देनी है 10 grams देनी है 50% magnesium sulfate की, and IV डोज देनी है 4 grams 20% magnesium sulfate की. In other words, जो टोटल लोडिंग डोज देनी है IM plus IV मिला के, that becomes 14 grams, 10 grams in buttocks as IM dose, 5 in each, plus 4 grams IV. So total loading dose जो हमें magnesium sulfate की देनी है, that is 14 grams. Now I want all of you to listen to me very attentively. क्योंकि questions जब पूछे जाते हैं, ये देखा जाता है that whether you attended your wards or not, whether you have done your clinics or not, whether you have practical knowledge or not. क्योंकि इतना रट लेना तो बहुत आसान है कि 10 grams हमें IM देना है, 4 grams IV देना है. Now they are going to test your practical knowledge, and since you people have not been to labor room once also, this practical knowledge I am giving you. Now labor room में जो magnesium sulfate का ampule available होता है, that ampule is 2 ml ampule, right? So in all the labor rooms जो magnesium sulfate का ampule available होता है, that is 2 ml ampule, which has 50% magnesium sulfate. So this is maths कि 2 ml में अगर 50% magnesium sulfate है, तो 2 ml में 1 gram magnesium sulfate होगा. Right? So a 2 ml ampule will have 1 gram of magnesium sulfate. Now I told you कि जब एक एक्लैम्शिया की पेशेंट आती है और हमें उसे मैग्नीशियम सल्फेट देना है, तो हमें उसे इनिशियली 14 grams देना है. So if I ask you that a patient of eclampsia is entering into labor room and you are gynae resident first year, total कितने ampules of magnesium sulfate are you going to pick up? How many ampules of magnesium sulfate are you going to pick up at one go? You need 14 grams of magnesium sulfate immediately, and 1 ampule में 1 gram होता है, तो immediately आप 14 ampules of magnesium sulfate के उठाओगे. Are you understanding? Immediately pick up 14 ampules of magnesium sulfate, right? अब इन 14 ampules में से जो IM dose है वो तो 50% solution की है. So IM dose में हम 5 ampules दे देंगे immediately in left buttock, and 5 ampules I am going to give in right buttock, because the magnesium sulfate which I have is 50%, right? And IM dose 50% की ही देनी है, but जो IV dose देनी है वो हमें देनी तो है 4 grams. We have to give 4 grams, but you have to give 20% solution. Now, the 4 ampules which are left, they are 4 grams, but they are 50% solutions. Magnesium sulfate जो available होता है market में is available in the form of 50% solutions. लेकिन हमें जो देना है, हमें 20% solution देना है. So, I have to first make 20% solution and then I have to give IV. And this was a very, very important MCQ which was asked in NEET, that how are you going to make a 20% solution? अब 20% solution बनाने के लिए what I am going to do is, see, I need 4 grams 20% solution. 4 grams 20% solution का मतलब है how many ampules I need? I need 4 ampules. Because each ampule has 1 gram magnesium sulfate. This is clear? So I am going to take 4 ampules, and in 4 ampules का I am going to make 20% solution. अब ये जो 4 ampules हैं जिसमें 4 grams magnesium sulfate है, इनका वॉल्यूम कितना है? Each ampule I told you is 2 ml. Each ampule is 2 ml. So 4 ampules means 8 ml. So what I am going to do is, I am going to take a 20 ml syringe. In this 20 ml syringe, I am going to add these 4 ampules of magnesium sulfate, that is 8 ml of magnesium sulfate. So I have added these 4 ampules. So this is 8 ml magnesium sulfate. 8 ml magnesium sulfate has 4 grams magnesium sulfate. अब जो remaining syringe में 12 ml है, I am going to put normal saline 12 ml. So now I am putting in the syringe 12 ml of normal saline. So इसका मतलब कि अब 20 ml बन गया, 8 ml magnesium sulfate, 12 ml हमने उसमें we have added normal saline. So total जो अब syringe में volume है, that is 20 ml. And उस total 20 ml में 4 grams magnesium sulfate है. In other words, I have made a 20% solution. And now this I am going to give as IV dose to my patient. Have you understood this? So whenever you are giving IM dose has to be 50% solution, and that is easily available in your labor room. But 20% solution you will have to make, and this is how you are going to make. So all the foreign medical graduates समझ लेना इसको बहुत अच्छे से. By chance नहीं समझ में आ रहा तो rewind करके once this session gets over, just listen to it again so that you understand how to make a 20% solution of magnesium sulfate. Right? Now, the other very important point about magnesium sulfate is, magnesium sulfate is a drug which has got very low therapeutic range. It is a drug with very low therapeutic range, and the therapeutic range of magnesium sulfate is 4 to 7 milliequivalents per liter. अब इसका क्या मतलब हुआ? इसका मतलब ये हुआ कि अगर मैग्नीशियम एक पेशेंट कन्वल्जन थ्रो कर रही है एंड जब मैंने उसको मैग्नीशियम सल्फेट दिया और अगर मैग्नीशियम का लेवल 4 से कम है उसकी बॉडी में, 4 मिली इक्विवेलेंट्स पर लीटर से कम है, तो उसके कन्वल्जन्स कंट्रोल नहीं होंगे. शी विल कंटिन्यू टू थ्रो कन्वल्जन्स एंड जैसे ही 7 से ऊपर पहुंच जाएगा शी विल शो मी साइंस ऑफ टॉक्सिसिटी. सो वेरी वेरी नैरो थेरेपेटिक रेंज. 4 से कम है मैग्नीशियम तो पेशेंट का कन्वल्जन नहीं कंट्रोल होगा. 7 से बढ़ गया तो पेशेंट में टॉक्सिसिटी होनी शुरू हो जाएगी. राइट? So that is why before giving each maintenance dose, you have to check for magnesium sulfate toxicity. Now, one question for all the NEET PG aspirants who are watching this video. Do you check these parameters before you give the loading dose? No. You are not going to check these things before you give the loading dose. All these things have to be checked only before you give maintenance dose. What is that one thing which you check before you give the loading dose? So before you give the loading dose, you check maternal heart rate. That's the only thing which you have to check before giving loading dose. But this will not be asked in foreign medical exams, right? So coming back to our topic. Now, before giving maintenance dose, you have to check for magnesium sulfate toxicity, and magnesium sulfate toxicity को check करने का there are 3 ways. Number 1, I am going to check for patellar reflex. Patellar reflex is knee jerk. Knee jerk. Normally in a patient of eclampsia, these reflexes are exaggerated. Normally ये reflexes exaggerated होते हैं in a patient of eclampsia. Abnormal है if it is absent. Right? Then urine output. Normally urine output should be more than equal to 30 ml per hour. If it is less than 30 ml per hour, it is abnormal. Respiratory rate should be more than equal to 12 breaths per minute. If it is less than 12 breaths per minute, then that is abnormal. Now, if everything is normal, then you will give maintenance dose. If any of these things is abnormal, if any of the above is abnormal, you will withhold the maintenance dose. You will withhold the maintenance dose. You will not give maintenance dose. You are going to withhold it. Clear? Now, just let me give you an example कि कैसे देते हैं magnesium sulfate so that you understand withholding का क्या मतलब है. Suppose it is 12 o'clock in the afternoon. You are in your labor room and a patient of eclampsia comes and immediately heart rate mother की check करने के बाद I have given the loading dose. Right? So I am going to make a chart जिसमें I am going to write that the loading dose was given at 12 o'clock. Now after 4 hours I have to give maintenance dose. Now before I give maintenance dose, I am going to check her patellar reflex, I am going to check the urine output and I am going to check respiratory rate. अगर इन तीनों में से कुछ भी abnormal हुआ, तो at 4 o'clock I am not going to give her the maintenance dose. अब next dose का time आएगा again after 4 hours, तो 8 o'clock at night I am going to check these things. 8 o'clock पे भी अगर मान लो patellar reflex absent है, so again at 8 o'clock I am not going to give her the dose. Then I am going to go at 12 o'clock at midnight. Are you understanding how you have to give magnesium sulfate? Yes. Now, what are the signs of magnesium sulfate toxicity? First sign of magnesium sulfate toxicity is absent knee jerk. Knee jerk is absent if magnesium becomes more than equal to 10 milliequivalents per liter. So if the levels of magnesium become more than equal to 10 milliequivalents per liter, then the knee jerk is absent. Number 2, you can get slurring of speech, diaphoresis. Diaphoresis क्या होता है? Excessive sweating. Then respiratory depression, respiratory arrest, and cardiac arrest. All these are signs of magnesium sulfate toxicity. One very, very important question is urine output, decreased urine output. It is not a sign of magnesium sulfate toxicity. So oliguria is not a sign of magnesium sulfate toxicity. So now you're going to ask me, ma'am, if oliguria is not a sign of magnesium sulfate toxicity, तो हम बार बार ये चेक क्यों कर रहे थे कि यूरिन आउटपुट कितना है? And if urine output was decreased, आपने कहा we are not going to give magnesium sulfate. We were checking urine output because magnesium sulfate is excreted through kidneys. तो अगर किसी पेशेंट का यूरिन आउटपुट डिक्रीज्ड होगा तो मैग्नीशियम सल्फेट का एक्सक्रीशन नहीं होगा एंड चांसेस ऑफ टॉक्सिसिटी विल इंक्रीज. आर यू अंडरस्टैंडिंग? सो यूरिन आउटपुट में अगर डिक्रीज है इट विल लीड टू मैग्नीशियम सल्फेट टॉक्सिसिटी. मैग्नीशियम सल्फेट टॉक्सिसिटी की वजह से डिक्रीज यूरिन आउटपुट नहीं होता. सो इन शॉर्ट, decreased urine output is not a sign of magnesium sulfate toxicity. Is that clear to all of you? Yes? Now, what is the antidote for magnesium sulfate toxicity? What was magnesium doing? Magnesium was blocking the calcium channels. So, if there is a magnesium sulfate toxicity, I am going to give calcium gluconate. If calcium gluconate is not available, I can give calcium chloride. Right? Now, since we have done everything about antihypertensives, we've done everything about magnesium sulfate, quickly we are going to see how to manage a patient of PIH. Okay. So, I have made a table for you where I have written condition, symptomatic management and definitive management. Mild pre-eclampsia. Mild pre-eclampsia का मतलब BP more than 140 by 90 but less than 160 by 110. तो symptomatic management में क्या करेंगे? Antihypertensive if BP is persistently more than 150 by 100. What will be the drug of choice? The drug of choice will be oral labetalol, which you have to give BD twice a day. What will be the definitive management? Termination of pregnancy at more than equal to 37 weeks. Now, if a patient of severe pre-eclampsia comes to you, that means BP of the patient is more than equal to 160 by 110. So, ऐसे patient में सबसे important thing about which I am worried is that this patient at any time can throw convulsion. So, the first step which I have to do, is I have to prevent convulsions. And how am I going to prevent convulsion? I am going to prevent convulsion by giving magnesium sulfate. Now, because BP is more than 160 by 110, तो definitely हमको antihypertensive देना है, and I am going to give IV labetalol. What is definitive management? Definitive management is termination of pregnancy, which you have to do at more than equal to 34 weeks. Now, eclampsia patient. eclampsia की patient आई है and if I ask you, एक patient convulsion throw करती हुई आ रही है, तो जब एक patient convulsion throw करती हुई आती है, then the tongue of the patient goes back and it blocks the airway, right? So the first step is airway management. Do not say I'm going to give magnesium sulfate. Magnesium sulfate is the first step in severe preeclampsia. First step in eclampsia is airway management. Now by chance अगर कोई nursing student इस वीडियो को देख रहा है, for you people the first step is कि patient को हमें गिरने से बचाना है. So for you people you are going to say that I am going to put the bed rails on. बेड की रेल्स को ऊपर खींचोगे so that patient doesn't fall, and then you are going to go to airway management. For all the medical students, whether you are foreign medical graduate, whether you are NEET PG, the first step is airway management, right? Second step is magnesium sulfate to treat convulsions, and simultaneously हम उसको antihypertensive भी देंगे. I am going to give her IV labetalol. What is the definitive management? Definitive management is immediate termination of pregnancy, irrespective of gestational age. Immediate termination of pregnancy, irrespective of gestational age. Clear? Now, what is the mode of delivery? Mode of delivery in a patient of PIH is always vaginal delivery. In patients of eclampsia, if vaginal delivery does not happen within 24 hours, if within 24 hours vaginal delivery does not happen, then you are going to go for cesarean section, right? Now, when you are doing cesarean section in a patient of PIH, what is the anesthesia of choice? The anesthesia of choice is epidural anesthesia. Epidural anesthesia, right? Now all these important points I have done with you. Now I want all of you to come on page 157. 157. Now in patients in PIH, there is uteroplacental insufficiency, and because there is uteroplacental insufficiency, I am going to do umbilical artery Doppler. I am going to do umbilical artery Doppler. Now umbilical artery Doppler में you will get systole के time पे blood flow, diastole के time पे blood flow, then systole, then diastole, like this. That is how a Doppler appears like. So normally क्या होता है in pregnancy, जैसे जैसे pregnancy advance करती है, वैसे वैसे जो blood vessels की resistance है वो कम हो जाती है, right? And the amount of blood flow during diastole increases. So normally क्या होता है, this if it is in early pregnancy, so if this is a Doppler of early pregnancy, when you are going to see Doppler, normal Doppler in late pregnancy, you will see that the blood flow during diastole increases. जैसे जैसे pregnancy advance करती है, blood flow during diastole increases, right? So write down this. Normally, as pregnancy advances, blood flow during diastole increases, right? So if I ask you what happens to the ratio of blood flow during systole and diastole, so I am telling you कि जैसे जैसे pregnancy advance करेगी, diastole में the amount of blood flow will increase. Systole में same रहेगा, diastole में it is going to increase. So if denominator is increasing, what happens to SD ratio? SD ratio decreases. So normally in pregnancy, SD ratio of umbilical artery decreases. I'm just explaining it to you once again so that just in case you missed out. See, Doppler में जब भी होता है, when we do umbilical artery Doppler, you are going to see systole की peak and diastole की peak. Blood flow during systole, blood flow during diastole. Now, as pregnancy advances, this is something which happens normally. As pregnancy advances, blood flow during diastole increases. During systole, it will remain same, but during diastole, the blood flow will increase. So, if I ask you, what happens to SD ratio normally? You are going to say normally the SD ratio decreases, right? अब PIH के patients में क्या होगा? In patients of PIH, as BP increases, blood flow during diastole decreases. Pressure and volume are inversely related, right? So what is going to happen to SD ratio in a patient of PIH? Diastole decrease कर रहा है, denominator decrease कर रहा है. So what is going to happen to this ratio? This ratio will increase. And if it becomes more than 3, then it means there is mild preeclampsia type की condition and you have to do termination of pregnancy at more than equal to 37 weeks, right? So यहाँ पे देखो, अगर ये blood flow था normal, इतना सिस्टोल इतना डायस्टोल, तो PIH के पेशेंट्स में डायस्टोल के टाइम पे ब्लड फ्लो विल डिक्रीज. सो SD रेशियो विल इंक्रीज and termination of pregnancy will be done at more than equal to 37 weeks. अब जैसे जैसे ब्लड प्रेशर और बढ़ेगा, now as BP increases further, अब क्या होगा? जैसे जैसे BP और फर्दर बढ़ेगा, there will be no blood flow during diastole. No blood flow during diastole. This is called as absent end diastolic flow. Absent end diastolic flow. And if you are getting absent end diastolic flow, then termination of pregnancy has to be done like in patients of severe preeclampsia at more than equal to 34 weeks. Right? अब इससे भी serious condition होती है. So look over here. In this Doppler during diastole, there is no blood flow. Right? So this is absent end diastolic flow. And in absent end diastolic flow, termination of pregnancy has to be done at more than equal to 34 weeks. As BP further increases, now what is going to happen? Now there will be reversed blood flow in diastole. So instead of कि ब्लड प्लेसेंटा से अम्बिलिकल आर्टरी की तरफ, वेसल्स की तरफ आए, now there is going to be reversed blood flow, right? And this is how reversed blood flow will look like. So this is called as reversed end diastolic flow. Reversed end diastolic flow. And whenever you have reversed end diastolic flow, pregnancy should be terminated at more than equal to 32 weeks. Around 2 years back, कहा जाता था, it has to be terminated immediately. Now they say it has to be terminated more than equal to 32 2 weeks, right? So when you get reverse end diastolic flow, it has to be terminated at more than equal to 32 weeks. Now just quickly let me show you all these images. So look here. This is normal waveform. In normal waveform, this orange color line is showing you blood flow during systole. Green color line is showing you blood flow during diastole. Right? Now, look over here. Look at this Doppler. In this Doppler, what are you seeing? In this Doppler, you are seeing there is no blood flow during diastole. So this is absent end diastolic flow. When you have absent end diastolic flow, you have to terminate pregnancy at 34 weeks. Now look at this Doppler over here. What are you seeing? Over here, you are seeing that blood flow is happening in reverse direction in diastole. So this is reversed end diastolic flow. And if you get a Doppler like this, you are going to terminate pregnancy at 32 weeks, right? And someone was asking me that are you going to give steroids? Yes. अगर आप पेशेंट को कभी भी डिलीवर करने वाले हो 34 या 32 वीक्स पे, you have to give steroids. Before 37 weeks, you have to give steroids. Now this over here is a uterine artery Doppler. Uterine artery Doppler mein, can you see these orange arrows which I have marked? This is what is a diastolic notch. So this is systolic phase. This is diastolic phase and this is the notch. Right? So normally this notch should disappear by 22 to 24 weeks. But if this notch doesn't disappear, then it predicts the chances of PIH. I hope PIH is clear to all of you. Yes? Yes, any confusions? Just let me know. So that brings us to the end of this session. It is 6:37. Shall we resume the class in Church Hall at 7:45? Will that be enough time for all of you to have your dinner? 7:45 पे फिर से class start करें? All the Bishkek students, tell me quickly. 7:45 should we start the class? Okay. So, in Church Hall, we are going to resume the class at 7:45 और 8 के बीच में करेंगे. 8 will be too late. चलो 8 o'clock we are going to start. 8 o'clock. 8 o'clock we will start the class. Right? And then we are going to continue. 8 o'clock, fine. That's why I'm saying 8. I'm now. So you have to take dinner na beta. Tabhi to I'm giving 6:45, 6:40 ho raha abhi. I'm giving you more than 1 hour. So we'll discuss it on the Telegram group now. Take care. Bye. See you again in the